Most clinicians are trained to recognize panic and emotional intensity, but the clients at greatest risk are often the ones who go quiet. When clinicians think of trauma, they often think of intensity, panic, anger, emotional flooding, and those are real. But there is another presentation of trauma that is quieter and often more dangerous because it is missed. In substance use disorder treatment settings, this becomes especially important. Many clients in SUD treatment have significant trauma histories, and rates of PTSD are high in this population. As substances are removed, what was numbed becomes exposed. In many cases, the substance has been regulating the trauma. So what we are seeing is not just addiction. We are often seeing trauma unmasked. Today, I want to talk about PTSD, the defense cascade, and why many clinicians overfocus on what I'll call Uproar PTSD, while overlooking Shutdown and Dissociation. PTSD involves exposure to a traumatic event followed by 4 clusters of symptoms: intrusion, memories, nightmares, flashbacks; avoidance, avoiding reminders of the trauma; negative changes in mood and cognition; guilt, shame, detachment; arousal and reactivity; hypervigilance, irritability, sleep disturbance. These symptoms persist for more than 1 month and cause impairment. That's the structure. But how those symptoms are expressed, that's where clinical nuance matters. One useful way to understand trauma responses is through the defense cascade. Very simply, fight, flight, freeze, shut down, collapse. In the early stages, the body is sympathetically activated, energy is mobilized, the person is prepared to act. In the later stages, the system shifts toward parasympathetic dominance, energy drops, the system begins to shut down. This is not a choice. It is a biological progression when threat cannot be escaped. Most clinicians are well trained to recognize what I'll call uproar PTSD. This includes panic, anger, hypervigilance, emotional reactivity, agitation, intrusive memories with high intensity. These are sympathetic dominant states. They are loud, they are visible, they demand attention, and because they are obvious, they are often treated. But there is another presentation, shutdown PTSD. This includes emotional numbing, detachment, reduced responsiveness, low energy, withdrawal, dissociation. These are parasympathetic dominant states. They are quiet. They are often misinterpreted. Clients may be described as not engaged, flat, unmotivated, resistant. But what may actually be happening is neurobiological shutdown. Dissociation often emerges in these later stages of the cascade. It is the nervous system's way of creating distance from overwhelming experience when escape is no longer possible. Clinically, dissociation may look like a blank or distant stare, slowed or delayed responses, confusion or disorientation. I feel unreal. This doesn't feel real. Difficulty tracking conversation, emotional numbing, partial amnesia. These are not signs of disengagement. They are signs of defensive shutdown. Clinicians are often trained to respond to activation. We notice panic, anger, emotional intensity, but we often overlook stillness, silence, disconnection, because those states do not demand attention in the same way. But clinically, they can represent deeper dysregulation, reduced capacity for engagement, increased vulnerability, and in some cases, increased risk. When a client is in uproar, we tend to help them calm down. When a client is in shutdown, we often try to engage or process, and that is where mistakes happen. If a client is dissociated or shut down, processing will fail. Insight work will fail. Emotional exploration may increase disconnection. The task is not processing. The task is reconnection and stabilization. In shutdown or dissociation, the goal is to gently bring the client back into the present. This may include grounding attention in the environment, orienting to the room, slowing the pace, using simple, concrete language, encouraging physical awareness. The goal is to restore enough regulation for the client to re-engage. Processing comes later. A simple way to remember this: uproar PTSD is loud. Shutdown PTSD is quiet. Both are dysregulated. And importantly, the quieter presentation is often the one we miss. In addiction treatment settings, crisis is not always loud. Sometimes it presents as panic and intensity, but sometimes it presents as absence, disconnection, numbing, and withdrawal. If we only attend to emotional intensity, we will miss a significant portion of trauma presentation. And in SUD settings, where dysregulation is already amplified, this distinction becomes even more important. So the task is not just to notice who is overwhelmed, it is to notice who has disappeared, psychologically, emotionally, or relationally. Because in those moments, the work is not exploration. It is helping the client come back. This video is intended for educational purposes for licensed clinicians and trainees. It is not a substitute for clinical supervision, agency policy, or emergency protocols. In all cases of acute risk, follow your organization's procedures and applicable laws, and consult with appropriate supervisors or emergency services as needed.